Thank you very much, and thank you for the organising committee for asking me to speak today. It's great to see so many GPs here on a Sunday afternoon. So I'd like to start the talk with this video, which I think sets the scene quite well for this talk.
It started out like a totally normal day. Okay, move objection deadline to the third line after survey. Oh, honey. So when you write, always use the breakfast.
Okay, move objection deadline.
What's going on there? Did you finish your breakfast?
What's going on there? Did you finish your breakfast?
Don't hit your brother. Honey, you have to eat something. Here. Okay, 5 minutes to carpool.
Don't hit your brother. You have to eat something. Here. Okay, 5 minutes
You
to
okay,
carpool.
Mom? Oh, I'm fine. Sandwich orders. What do you want?
Almond butter and yolk.
You okay, Mom? Oh, I'm fine. Sandwich
You
orders.
sure you're okay?
I'm fine, sweetie.
I am so late. Hey, buddy, how you doing? Hey, honey.
I'm fine, sweetie.
You okay?
Yeah, I'm fine.
You sure?
Oh, yeah. Here.
Acai, my favorite.
You okay?
See you guys later.
Sure.
Put your shoes back on, please. You know, go help your sister.
Wear your shoes.
We're going in 3 minutes.
You know,
Oh, my God, what am I doing? I forgot to cut off the crust.
God, what am I
Voila.
doing?
Shoes on, potty if you need it.
I forgot
Get your
to cut off
sister.
the crust.
Okay, get your shoes.
Voila.
Nobody
Shoes on,
move.
potty if you need
Getting
it.
a dustpan.
Get your sister.
Mom! I think you're having a heart attack.
Honey, do I look like the type of person who has a heart attack?
I think you're having a heart attack.
Totally fine. Don't forget to wear the high socks with the shin guards.
Forget about the shin guards, Mom.
Come on, Mrs. Underdog is not going to wait.
Socks with the shin guard.
Forget about the shin guards, Mom.
Come on, Mrs. Underdog is not going to wait.
Whoa. Okay. 9. Okay. Hi, sorry to bother you. I think I might be having a little heart attack.
I'm sorry to bother
Nothing
you.
really, just some nausea.
I think I might
Tightening
be
of the jaw,
having
dizziness,
a
shortness of breath, muscle pain, achiness, this
Nothing
terrible
really, just some
pressure
nausea.
in my chest.
Tightening of the jaw, dizziness,
Oh, really?
shortness of breath, muscle pain, achiness.
They can be here in how long?
Terrible pressure in my chest.
2 minutes.
Oh, really? They can be here in how
Can you
long?
make it 10?
2 minutes.
I thought I had gas. Turns out I was having a heart attack. Heart disease is the #1 killer of American women.
thought I had
So
gas.
now I take care of my heart, and I
Turns
tell
out
the women in
I
my
was
life
having
to do the same.
Heart
Sounds
disease
great, by
is the
the way.
#1 killer of America.
That's nice, sweetie, but that's
So
not my
now I
heart.
take care of my heart,
That
and I
is.
tell the women in my life.
Make it your mission to save your life and the lives of the women you love. Find out more from the American Heart Association at
Make it your mission to save your
GoRedForWomen.org.
life and the lives of the women you love. Find out more from the American Heart Association at GoRedForWomen.org.
Okay, so I think many of us in the audience can probably relate to that video in some way, particularly the women in this room. So the topic of my talk is female pattern ischemic heart disease, or why do women have more adverse ischemic heart disease outcomes compared to men? So we'll talk about the scope of the problem, sex and gender differences, awareness in women, in the general public, as well as doctors about this, risk factors for cardiovascular disease in women, and where we are now in terms of cardiovascular disease mortality. So cardiovascular disease kills more women each year than the next 4 causes of death combined. This is not a small problem. Can anyone tell me who the woman on the left-hand side of the screen is? Barbara Streisand. Yes, that's right. And which movie is she starring in here? The Yentl. Yep, absolutely. So Barbara was calling attention to the fact that at the turn of the 19th century, to be educated in Eastern Europe, you had to be a man. So what did Yentl do? She dressed up as a man to receive her education. And the woman on the right-hand side is Dr. Bernadine Healy. She was the director of the National Institute of Health at the time that the Yentl movie came out. And she wrote an editorial in the New England Journal of Medicine called The Yentl Syndrome. And that was calling attention to these demographics. There was an epidemic of cardiovascular disease deaths in women. The blue bars that you can see over here represent cardiovascular disease mortality in men, and the pink bars are women. So we were winning the war in men, but we were not winning that war in women. More women died in 1984 subsequently of cardiovascular disease than men, and there was a massive reversal over a very short period of time, too soon for genetic change or risk factor modification, and this suggested to National Heart, Lung and Blood that we needed to study women's heart disease, that the research and the clinical gains that we as clinical cardiologists had conducted in men, for men and by men perhaps were not serving women so well. And so a number of clinical trials were then commissioned. So early on, it was recognised that more women were dying than men during their infarct hospitalisations, and there was a theory to this. So can anyone tell me which two things in life are inevitable? Death and taxes, yeah, absolutely. So because women on average lived longer than men, it was thought that it was the older women in nursing homes, and you had to die something, so you died of a heart attack. And so that's what the epidemic was thought to be about, and Viola Veccarino hypothesised that it would be the older women. But in fact, it was also the younger women who were affected. And with the average age of menopause of 52, 53 years of age, these were also premenopausal women. So the death and taxes explanation didn't seem to explain this. And in 2005, the National Heart, Lung and Blood Institute, which is the equivalent of our National Heart Foundation, commissioned some studies into cardiac syndrome X. It's a term we don't use anymore, but it used to refer to open artery ischemic heart disease or hysterical women. And so there was a systematic review of clinical trials and registries that had angiographic core labs. And they asked the question, how often do women have acute coronary syndromes with open arteries? And they saw that in unstable angina, this occurred in up to 30% of women. In non-STEMIs and STEMIs, this could be in up to 10% of women, compared to half this disease prevalence in men. And so 60 years of research in men, for men and by men essentially sold us on the fact that the only way you could have a heart attack was to have plugged up epicardial arteries. But is this really the case? None of this was remarked in any of these studies. So we since have come up with this term called MINOCA. And this has come around in the last 4 or 5 years, and it suggests that there is evidence of a myocardial infarction with normal or near normal coronary arteries on angiography, so nothing flow limiting. And this occurs in up to 25% of all myocardial infarctions. So of troponin-positive, non-obstructive coronary artery disease, we can divide this into a few groups. There are myocardial disorders like myocarditis, Takotsubo cardiomyopathy, and the non-cardiac disorders that can cause troponin rises like chronic kidney disease, pulmonary embolism that puts stretch and strain on the right heart, and then the coronary disorders, which we now refer to specifically as MINOCA. In previous years, we would refer to this whole group as MINOCA, but now we prefer to refer to this coronary disorder group preferentially. And these are people with coronary dissections, plaque ruptures, coronary spasms, and endothelial dysfunction. So in terms of investigating this, we would take a good clinical history, ECG, do our cardiac enzymes, do an echocardiogram, looking for wall motion abnormalities, and coronary angiography, and maybe a left ventriculogram during the angiogram. And if we see regional wall motion abnormalities that are limited to a single epicardial coronary artery territory, then this may suggest an epicardial pattern. But if there are regional wall motion abnormalities that extend beyond the single coronary vessel, then this may suggest a microvascular pattern. And sometimes we need to go on to cardiac MRI to give us further clues as to what is the cause. So what about sex and gender differences? This is a male physician talking to his female patient, saying, we have studies of fruit flies, mice, hamsters, frogs, monkeys and men with this condition, but medical research using women as subjects just never occurred to anybody. And it is true, fewer women have been included in studies, so there really is less data. But cardiovascular disease is an equal opportunity killer. In typical cardiovascular disease trials, 85% of participants are male, and women who do or who did participate are predominantly postmenopausal women. And why were randomised trials avoided in women in the 20th century? Well, this had something to do, we think, with the birth defects in children who were exposed to thalidomide in utero. You've all heard about that. And the recognition that pregnant women taking part in these trials could result in fetal injury. And so we were really scared then to investigate new drugs in women who are of childbearing potential. And added to that, in that era, the 50s and 60s, the effectiveness of contraception was a bit more dubious, and so that led to a paternalistic approach to the design of clinical trials. This is a graph that shows the representation of women in clinical trials. You see, and that's spread by different diagnoses. The grey bars represent women in randomised controlled trials. The white bars represent women amongst the population who have that disease. And the black bars represent the percentage of women who die from that particular disease. So what we aim for is that participation in clinical trials is roughly equal to that of the disease prevalence. But we can see in coronary artery disease and in heart failure and maybe hypercholesterolemia that the largest gaps are in those areas, and that's probably due to the phenotype inclusion criteria. So what about sex and gender differences? Well, it is an undeniable reality. Women, whether you consider it a blessing or a curse, are provided with far more complex physiology surrounding their reproductive capabilities, and this has far-reaching impacts on their quality of health, cancer risk, and cardiovascular death. So just to go through some terminology, sex is the biological sexual differentiation. Women have ovaries, men have testes. But gender is the socio-cultural attributes of the biological sex. Women have complex social networks, and men have wives. This is solid stuff, guys. I can give you the references to it if you require. So there are gender differences in reporting. Women are more comfortable discussing their feelings with friends and reporting their symptoms to their doctors, but women are more likely to wait before presenting to medical attention. And you saw in that video with Elizabeth Banks a hint of that also. There are also gender differences in how a physician responds to these symptoms in women. Physicians are more likely to evaluate men compared to women, and women are referred less often for appropriate testing or treatment. So this is a study of 35,000 patients with non-ST elevation MI, of which 41% were women. And women in this study had more diabetes, more hypertension, and were older. They had less use of aspirin, heparin, glycoprotein, 2B3A inhibitors, and ACE inhibitors, less revascularizations compared to the men, and were less often discharged on our 4 magic pills: aspirin, beta blockers, ACE inhibitors, and statins. And they had a higher risk of death, subsequent MI, and heart failure. But we know that in previous trials, men and women have a similar effect or benefit to our treatment therapies. So I'm just going to stop for a little bit and talk you through a few cases that I saw in just one of my recent on-calls at the hospital. So this is Jill. She's a 72-year-old lady. She had some central chest discomfort. She thought it was indigestion, so she took some charcoal. She'd had indigestion before, and so she'd been on Losec in the past, which gave her pancreatitis. So hence she had this stock of charcoal at home. But the pain worsened, so she went to Barrow Hospital. And this is her ECG. Shows sinus rhythm, and some anterior ST elevation. So she was started on dual antiplatelet therapy, IV heparin, and she was thrombolyzed, but she failed to reperfuse and was sent to Liverpool Hospital for rescue PCI. This is her coronary angiogram. And you can see here that there's an occlusion of the left anterior descending artery and the left circumflex artery is patent. And on the right-hand side, you see the right coronary artery, which is completely normal. In the left-hand side image, you see that she underwent balloon angioplasty to her proximal LAD. You see the balloon sitting here in the proximal artery. This is the guiding catheter. And in the right-hand image, you see the final result. And you can see blood flow flowing quite freely now down the left anterior descending artery. Oops. So this is her echocardiogram. And you can see that there is some subtle hypokinesis here in the septum and also in the anteroseptum, and the rest of the walls are normal. So there's overall preserved left ventricular systolic function. The next patient's Joanne, and she came in on the same day. She was a 58-year-old lady from Campbelltown Hospital. She had symptoms of shortness of breath, left arm tightness, jaw ache, sweatiness and nausea, but no chest pain at all. And she had been a smoker and had high cholesterol, and she was taking a statin for that. She also has multiple sclerosis, and she'd had a berry aneurysm clipped in the past and has depression. She lives alone, and her father died from a subarachnoid hemorrhage, so she's really, really worried about this. So when we talked to her about the fact that, according to her ECG and her symptoms, she's got this anterior ST elevation, just like the previous patient, that she's probably having a heart attack, she refused thrombolysis due to concerns about having an intracranial bleed. And so she was transferred from Campbelltown to Liverpool Hospital for primary PCI. And on the image on the left, you can see the left anterior descending artery, and you can see that there is some hold-up of contrast in the distal LAD and some staining, and that represents a coronary artery dissection. And this is the right coronary artery, which looks beautiful. So we're expecting that to see on the left ventriculogram that because this coronary artery dissection affects the distal left anterior descending artery, that the myocardium supplied by that artery is affected, maybe akinetic or hypokinetic. But what we see is that the mid and the distal anterior walls are akinetic, and we were also surprised to see that the mid and distal inferior wall are also completely akinetic, but that the bases of the heart are hypercontractile. And this appearance on left ventriculogram is quite classic of Takotsubo cardiomyopathy. And these findings were also confirmed on her transthoracic echocardiogram. Similar wall motion abnormalities that affect the mid to distal half of every wall, so this affects every coronary territory. And when I looked at this echo, I was a little bit worried. I'm not sure if you can appreciate it in this light, but just at the apex, you see a little bit of white haziness. And I was worried that there might be a left ventricular thrombus. So we went on to do a DEFINITY echo where we inject some contrast dye whilst we take the echo, and it helps us to classify the blood pool a lot better. And it told us that there wasn't any thrombus there. So women are indeed a lot more complex. This lady had a coronary artery dissection as well as Takotsubo cardiomyopathy. So the last patient is an 88-year-old lady who came into hospital with 3 days of worsening dyspnea, bilateral, shoulder and jaw ache. And when I questioned her further, in fact, she'd been short of breath for about the last year, and that was since she had her hip replaced. So she fell, had a hip replaced, came home from hospital, put herself to bed and only got up to eat and go to the toilet. Shortly after that, she was diagnosed with breast cancer and chronic lymphocytic leukemia. And then in June of this year, she was diagnosed with giant cell arteritis, for which she was commenced on high-dose prednisone. And due to the immunosuppression following that, she develops scalp shingles. And in the past, she had been started on Cartier for atrial fibrillation by her cardiologist. And she has a history of depression, reflux, and chronic kidney disease. These are her medications. On arrival, she was in biventricular failure, and she also had clinical signs of pulmonary hypertension. This is her ECG. She's quite tachycardic, and you can see that there is some inferior ST elevation. She went on to have a coronary angiogram. And this is the LAD, the left circumflex artery. Curly vessels, but no significant stenosis. And this is her right coronary artery, and you can already see that there's a hold-up of contrast, and this may be a coronary artery dissection or a plaque rupture. But nevertheless, it's very small in the distal posterior descending artery, which is a very small vessel, so it wasn't stented. And this is her echocardiogram. You can see here that there are inferior and posterior wall motion abnormalities, but otherwise overall preserved LV function. And this is just an unzoomed view of her apical four-chamber view, and you can see that in fact the right ventricle is a lot bigger than the left ventricle, and that should never be the case. Okay, so that it tells us that there is either volume or pressure overload to the right heart. In fact, her pulmonary pressures were about 75 millimetres of mercury, which are extremely high. They should be less than 35. And so we went on to do a VQ scan, just because she had chronic kidney disease already. We'd already given her a dose of contrast for the coronary angiogram, so we thought we'd spare the kidneys an additional load. And she was diagnosed with multiple bilateral segmental pulmonary emboli and started on warfarin for that. So she had a late presentation inferior STEMI. She had chronic thromboembolic pulmonary disease precipitated by her immobility after her fractured NOF in the setting of malignancy. And she had heart failure precipitated by steroid use for her giant cell arteritis. This is a study that looked at the impact of guideline implementation for acute coronary syndrome on differences in survival between men and women. And so what you can see here is, so the bottom line is survival in women before applying the guidelines for therapy for acute coronary syndrome, and this is the improvement in survival following guideline implementation. And this is after adjustment for disease severity, comorbidity, and treatment. So the mortality improves. And there is also some improvement, if you look at the top two lines. This one here is mortality in men before guideline implementation, and the top curve is mortality in men following guideline implementation. And the difference between the top two curves, this curve here and this curve here, that the blue arrow is showing you, shows that there is a persistent sex gap, and that there is still more work needed to understand the sex-specific pathophysiology to improve outcomes for both men and women. So there is a significant gender gap in ischemic heart disease mortality. Women, particularly younger women, face a more adverse ischemic heart disease prognosis, and adjustments for disease severity, comorbidity and treatment doesn't fully account for that gap. So what about awareness of this problem? This is a report or survey looking at trends in awareness of heart disease in women. There were 2,500 women included, and the survey occurred between the years of 1997 to 2012. And over the period of the study, they noted that awareness amongst the whole study population nearly doubled as a result of the education campaigns, that heart disease is the leading cause of death in women. So what are the symptoms? Well, chest pain or discomfort, which we all know about, but it could also be unusual upper body discomfort, shortness of breath, diaphoresis, unexplained fatigue, lightheadedness, or nausea. So pretty vague symptoms. And the most common symptoms were dyspnea, fatigue, and weakness. And there may even be a prodrome in the weeks leading up to this infarct of fatigue, sleep disturbance, dyspnea, indigestion, and chest pain. In the National Myocardial Infarction Registry, looking at more than 1 million men and women, nearly half of whom were female, 42% of women presented without chest pain, compared to 31% of men. And there was a higher in-hospital mortality for the women compared to the men, and younger women without chest pain were at the highest risk, and I showed you some of that data earlier. So these women who presented without the chest pain were sicker, and they fared worse. More had diabetes, they were later to present, more had non-STEMIs, and because of the problems in recognising the disease, there were less timely therapies initiated, so less use of antiplatelet therapies, heparin and beta blockers. And there were higher rates of sudden cardiac death in men, but 63% of the women who did have a sudden cardiac death had absolutely no symptoms, no warning symptoms prior to that, compared to 44% of the men. So this slide just shows that as a result of the education campaigns over the years, there's been some improvement in the awareness of symptoms of ischemic heart disease, particularly in women, but this is still suboptimal. We've got a long way to go. So what about risk factors? We all know about the traditional cardiovascular risk factors, but there are some less well-known ones like menopause, obesity, high triglycerides, metabolic syndrome, couch potato, autoimmune disease and chronic kidney disease. Also cancer treatments like radiotherapy, depression and stress can increase the risk, as well as a history of trauma or abuse, and I think that may be particularly relevant in our area where we do see a lot of refugees. So there are also pregnancy-related risk factors, and Angela touched on these earlier, and these are often overlooked as a predictor of later cardiovascular disease. Pregnancy is often considered a stress test. Now, complications that occur in pregnancy may unmask a predisposition to cardiovascular disease later in life. For example, with preeclampsia and eclampsia, women are 12 times more likely to develop hypertension requiring treatment, more likely to develop cardiovascular disease, and more likely to die from cardiovascular disease. And women who have low birth weight babies compared to normal birth weight babies have 11 times higher risk of death from ischemic heart disease. It's alarming, isn't it? Women who have stillbirths or miscarriages have a higher risk of subsequent myocardial infarction, and those with gestational diabetes have a 70% increased risk of cardiovascular disease. So which risk factors may be more predictive in women? Well, low HDL may be more predictive than a high LDL, and Lp(a), which is a component of the bad cholesterol LDL, can be more predictive in the younger woman. Diabetes almost doubles the risk of a fatal MI, and the impact of smoking is far greater in women than in men. So it's associated with 50% of coronary events in women, even with very little use. And women who smoke have a 6 times higher increased risk of a heart attack compared to 3 times in men, irrespective of your age. So where are we now in terms of cardiovascular disease mortality? Well, here are the curves. As a result of research, guidelines, quality care and campaigns, there's been a 43% reduction in cardiovascular disease mortality. And we are now at parity with men. See that down here. Is that where we should be? We think we should probably be down here if we had it our way. So here are some take-home points for you. Cardiovascular disease is by far the biggest killer in women. Women can present differently and do worse when they do. Ischemia in the absence of obstructive coronary artery disease is prevalent and has an adverse prognosis and cost. The awareness has improved over the years, but I think it still can be improved. Prevention can reduce the risk. Don't forget the reproductive history. Results of ongoing studies on Minoka may help to guide specific management strategies, but we don't yet have these. And I'll leave you with this quote: "Nothing is more expensive than a missed opportunity." And perhaps for many of us, we've been missing many of these women. I know I probably have. Thank you.